Today's lecture would be on osteochondritis of hip. Okay, so synonym is avian, avascular necrosis of femoral head. Okay, I'll try to keep it as concise and on point as possible. It won't be all busy lecture and too much of pathophysiology and all those things. Okay, it's a quite important topic. Why? Because the incidence of this particular lesion is quite common, especially in Pondicherry. Why? Because cheap booze. Okay, so everyone drinks here. They have food or not, secondary, but they all drink. So drinking is one of the most commonest reasons why this thing happens. Okay, am I audible till the end? Yeah. Alright. So here the incidence of this problem is quite common. So it happens almost like 10 to 20,000 per year. So this was a small survey which they had done in the Northeast. It is quite common, they found. But the reason why it's happening is quite controversial. Some people tell it's because of stress, some people tell it's because of steroids. So let's just keep it to your textbooks. So most common reason is smoking, alcohol intake, steroid intake, people who had recent renal Okay, do we still keep having people now? We'll wait for another 5 minutes? Or shall we go ahead? Yeah, we'll go ahead. Okay. Yeah, so whoever has got a recent transplantation done, who have got a heavy dosage of steroid, so all these individuals are ones who are more susceptible for avian. So initially people will, come down to your clinic saying it's a dull hip joint pain, and then you give them a couple of paracetamols and send them home. So don't take things lightly. So you need to have a thorough clinical evaluation to be done, and then follow it up with a couple of radiographs so that you're completely sure that there's nothing happening inside. Okay, so most of the times they don't come yelling at you. They'll come with a subclinical kind of a pain, but don't undertreat them is the point. Alright, so here we will be talking about case scenario based assessment, how we assess the patient, and second, signs and symptoms with regards to the problem. Third is how we investigate further. So what on-point investigations are needed. Let's not beat around the bush. Just 6 investigations, you do it, bang, you get the lesion and then move on. And third, how you decide what treatment to be given. So it's all tailored for a specific stage of lesion. So you can't use the same thing for everything. Okay, so that is one. And then what are the most probable reasons for unilateral and bilateral cases? So here, somebody read it out. Who's roll number 10? Is there a roll number 10? Somebody? Okay, so somebody can just read. I'm sure you'll be audible. So let's start with, who is roll number 10? There's no roll number 10. Yeah, okay. So someone in front, 20. Nice statistical point is picked. Roll number 50. Okay, great. Yeah. Can you just read the scenario?
For around means it's staying in the left leg for 2 years and removed from the lower leg.
Relieved on rest and analgesics and increased on mobilization. And the pain was radiating to the knee. The patient is a known case of has a known case of smoking and alcohol intake since the past 22 years.
Okay, so what are the intriguing points? So what are the things which are driving you into some interesting points?
So the pain started before the deformity probably started, and it leaves on rest and it's increasing on mobilization, and the patient is a known case of smoking and alcohol.
So all the spices needed for an avian is there, right? So patient normally has pain. It initially starts off as pain. Yeah, so initially it starts off as pain and then later on it becomes a deformity. So that is a very key element in osteochondrosis, avascular necrosis. Okay, and second thing is, yes, evaluating the comorbidities and known case of intake of these substances are very much important. So this all will help you get additional information why he has landed up with that problem. Okay, so later on He had come, he had some positive findings. His joint line was tender. He had a fixed flexion deformity of 30 degree. He had coronal plane deformity of adduction of 20 degree and internal rotation of 10 degree. So that means he has almost reached the end stage of his problem. So normally you know, right, in synovitis there is a certain attitude, and in late arthritis there is a certain attitude. So initially it starts off with flexion, abduction and external rotation with apparent lengthening. And as the time progresses, it becomes shortened, the limb gets shortened, it becomes fixed in flexion, adduction and internal rotation. So this is the global rule. It doesn't change. Say it as infection or chronic inflammatory disorder or osteoarthritis because of senile reason, it's all the same. It doesn't vary. Okay, so later we did a special test. Trendelenburg test is positive. I'm sure you guys know what is Trendelenburg. So you ask the patient to stand on the affected extremity, he will not be able to balance. So he tends to fall off. So that means his abductor mechanism or the joint itself is compromised. Either the joint or the abductor, the muscle might be compromised. And then he has no vascular or neurological deficit. So what DDs can you think of? I know the class is on avian, so obviously it's avian first. Anything else? Can you see this kind of a similar picture in some other scenarios? Sorry? Roll number 15? Is there a 15 here? Yeah. What do you think, man? Okay, superior gluteal nerve injury. Will they have a deformity in that? Abduction, adduction, all this fixed coronal plane deformities? It's an extra articular, extra capsular problem, but definitely a Trendelenburg will be there. So everything which falls in. Any senile osteoarthritis will have this. If you see an old lady of 60 years, she will also have the same thing. Okay, so this case scenario will mimic everything. So that is why you need further investigation. Okay. So how do you proceed? So everybody who comes with this, get a basic blood line workup. Get your complete blood count, total count, your ESR, your CRP. So ESR will normally slightly be raised. Any chronic inflammatory condition, your ESR will be raised. And your CRP will be positive if the patient is having acute symptoms, active phase reaction proteins, and then you can probably get an X-ray. So what X-ray will you ask for? Cervical open mouth view? What do you ask for? Pelvis with AP, okay? You ask for an AP view X-ray. You want a standing X-ray or a sitting X-ray? So standing X-ray. Why does it matter? Okay, so all compensatory changes will be seen in a standing X-ray because the patient tries to, maintain balance. He doesn't want to fall off. So all those compensatory changes, one shot, you will be able to see on the standing X-ray. Second, you ask for a frog-leg lateral view. So you ask the patient to squat to get a lateral view X-ray. It's called as a frog-leg lateral. Then do you need an MRI? Yeah. So MRI will give you additional information. It will give an idea about the articular surface, the joint capsule, the musculature around. If any neurological deficits are there in the patient, that will also give you additional information. Do you want to get a bone scan? So bone scan is a latest advent which shows it has superior specificity for avian. Okay, it has a cold uptake. So wherever there is avascular necrosis, I'll show you pictures. Okay, these are all dry slides. I'm trying to just build up the thing so that you'll be able to orient better in the consecutive slides. Alright, so in bone scan what happens is the pickup is not great. So it's a radioactive dye which is being installed into the patient, and wherever there is increased inflammatory activity there will be more pickup. But in avascular necrosis, is there any bone formation? It's all just dead bone. So there will be hardly any uptake. So that's called as a cold uptake. Okay, so that's one. Do you want to get an arthrography? Anybody knows what an arthrography is? So arthrography is you inject a dye into the joint and take an X-ray. So that gives you a contour of the capsule as well as the articular surface. And then last CT. Does anybody want CT? So CT will just give you a contour of the bone. That's all. But it's not done on a regular basis. So that's why I put the question mark. Arthrography and CT are not mandatory things, but the top 4 or top 3 are quite mandatory. Okay, so that has to be done. So normally in blood, you will see an increased total count, increased ESR, and a positive CRP. Okay, so this person's X-ray was taken. So can somebody read it out? What are you seeing? Roll number 30. Who's 30? Absent? Yes. Okay. Forget about the left side. Just see what. Okay. Are you able to appreciate sclerotic rim? So read it out. Sclerotic rim, right? So this is the sclerotic rim. So this is the affected hip. You can see a small sclerotic rim over here. Okay. Why has that happened? So it's a protective mechanism. So wherever there is dead bone, it forms a rim around that, and then inside you see a radiolytic area. So that's where the bone is completely necrosed. Okay, so there you can't see any bone as such. Then joint space is maintained. So that means it's in an early stage or a late stage? It's in a very early stage. So patient has still not gone into a globalized arthritic stage. Still there is some range of movement. That is why the patient is just having minimal FFT of the T, and beyond that he's got range of movement. Okay. And then what else? Superior lateral weight bearing. So it's right in that area. So is this a problem? Are you happy if you have a cavitated relation here or here? So if you have it on the top, is it a problem or you can relax on it? It's a problem. Why? Because every time the patient weight bears, the load is going to fall on this and early collapse will occur. The same thing if it was here, then invariably it will last long. Okay, but unfortunately all the avians start from the superior lateral area. Okay, so that is why you need to be very fast in your treatment. Or else he might come to you with this picture today, after a couple of months, he'll have a flattened out femoral head, which is very difficult for you to treat and salvage. Okay, so that's the whole reason you need to take a call as soon as possible. Okay, so an MRI was taken. So you can see the same thing. So this is a normal femur where the density of the highlighting of the bone marrow is good, the signals are good. But if you see here, it's fully blackened out. So hardly there is any signal there. So that shows a necrotic bone. Alright. So again, bone scan, which shows reduced uptake. You see here there it is homogeneously uptaken, but here there is a cold uptake. There is hardly any uptake. Okay, so that's a bone scan. So how do you stage an avian? So avian, sit up. Yeah. So how do you stage an avian? Avian can start today, but it's not going to stay the same. It has to proceed forwards, right? So they are categorized into 4 stages by Fickett and Arlett, but then there is a new modification by Fickett and Arlett which has 6 stages. It's quite confusing, so let's stick on to 4. Alright. So the day 1, there is hardly any changes clinically. Patient will just have dull aching pain, but if you see the X-ray, it will be absolutely normal. Only an MRI or a bone scan can pick up. So there is no radiographic change at all in stage 1. Whereas if you see in stage 2, stage 3 and stage 4, slowly the problem advances. So by stage 3 you will have a sclerotic rim and you will have that crescent sign. So the crescent sign is what depicts the necrosis of the bone. So once the crescent sign starts off, you know what's a crescent, right? Half moon shape, right? So once that crescent sign appears, then later on as the patient continues to weight bear, it breaks and then completely it flattens out. So the stage 4 is the worst stage. So where do you want to treat the patient? When will you be happy? Or at least you will give him some promising results. Stage 1, 2, 3, 4, where? So cutoff will be stage 2. Okay. So a patient lands up in these 2 stages, you can do a world of a difference for him. Okay, so here you can probably treat him better, the prognosis will be good, and patient's recovery will be better, right? Whereas he comes in the stage 3 or a stage 4 where the head is already flattened out, we can't play God, we have to accept, and it becomes a non-salvageable femoral head. Okay, so that's the problem. Okay, so you have quite a few reasons for unilateral and bilateral. So unilateral is most of the time post-traumatic period. Okay, so wherever there is a dislocation or a femoral neck fracture, or it is operated for another reason, where the surgeon has put the screw 2 into the head, or it has overly voided the end of the femur because of the reaming and everything, they can land up with avian. The bilateral ones are more systemic. Okay, so if he's got rheumatoid arthritis, it's not just going to focus on one femoral head or one thumb. It's going to be a globalized impact, right? So in those conditions, corticosteroid involvement, administration of other immunosuppressant agents like chemotherapeutic agents. Well, you're using neoadjuvant chemotherapy on tumor patients for GCT. When you see the X-ray, they will have developed an avian. So the loading dose of steroids are very key. So that is why the medical oncologists are very much intrigued on the fact they need to tighten them properly, or else they'll land up in trouble. Okay. So then after that, you have other inflammatory conditions like rheumatoid, Sjogren's, systemic lupus erythematosus. These are all other ankylosing spondylitis. These are all individuals who will invariably develop avian if they have not treated in an apt manner. Okay, so how do you treat them? So what is happening with avian? Can somebody tell what exactly is happening in avian? Roll number 25. Who's 25? Incognito. Okay, is that again? Okay. So it's going to take time. Okay, why don't you go ahead?
Sir, in avian.
Next time shuffle, huh? All of you guys will grab all the last benches.
Sir, in avian the bone is dying, the bone is getting necrosed.
Yeah.
Theory is that there is increasing intraosseous pressure, so the vascularity compromises, so that can lead to necrosis of the bone due to this pressure.
Okay. So again, it's chicken has come from the egg or egg from chicken story, right? So is it because of increased intraosseous pressure led avian, or is it because of bad blood flow? So it's actually the former, the latter. Okay, so there should be a compromised blood flow. It can be because of XYZ reason. It can be because of trauma. There can be a fracture neck femur which has dissipated all the retinacular vessels around the femoral neck, which has disconnected the blood flow to the head. That can be one reason. Or it can be because of vasculitis, because of rheumatoid arthritis, where all the vessels have shrunken and the patency of the blood flow is not great, and invariably it goes for avian. But ultimately it's because of compromised blood supply. Okay, so the causes might be different, but the endpoint is all the same. So because of that, the bone turnover in the femoral head becomes compromised. So there is more amount of deposition rather than resorption. Over a period of time, all that bone dies and it gets stacked up like necrotic bone. That will not have great subchondral support. So therefore the femoral head will collapse and flattens out, and an uncontoured, improper contoured joint, what will it land up with? Arthritis, premature arthritis. So it's like a chain of events. So initially it is compromised blood flow, necrotic bone, then necrotic bone fails to provide support to the articular surface. The articular surface flattens out and goes into osteoarthritis. Osteoarthritis, late arthritis, and then globalized restriction, and the patient is crippled on bed. Okay, so this is how the timeline works. So if you are having a stage 1 or a stage 2 where there is no globalized restriction, there is no great joint deformation, then you can go for these treatments. So you can give bisphosphonates. What do bisphosphonates do? Yeah, so it's a rank ligand inhibitor, right? So it basically knocks off the osteoclast activities. Once that pathway is switched off, it's more of calcium deposition, right? So that will improve the overall quality of the bone. So the per unit area of mineral density is improved. So that will provide good amount of strength to the subchondral bone, and it will prevent collapse. What about NSAIDs? What is that going to do? It's going to relieve pain. So pain is also a very critical part of your treatment. We are, at least as far as we are orthopedicians, we all aim in putting a plate or a screw, but it shouldn't work that way. Okay, we see a human, as a whole thing, package. So pain is very important. Second, what's the use of crutches? Yeah, so the joint reaction force in the hip joint is drastically reduced when you give crutches. So when you give crutches, the weight bearing on the bone is reduced, therefore the chances of wear and tear is reduced, and the advancement of your avian is macroscopically reduced. So that will buy him some time. It buys us also some time. So crutches are very crucial. Okay, so how do we decide when to go for surgery? So surgery is something, I know it gets us more money, brings us fame, all those things side apart. how do you decide? So you decide upon the area of involvement. If you have a very small area of involvement, you can always wait and watch. You can observe him, you can give him crutches, you can periodically call him, and then you keep seeing the progression of the disease, and then later on take a call for surgery, or else you can just continue with your conservative line of treatment. If he's drinking, ask him to stop drinking, send him for rehab or something. So it buys you time. But then if on day 1 itself he comes with a middle stage necrotic stage, then you take an MRI in AP and lateral, and this is called as a Cobble's index, okay, Cobble's angle index. So you take an AP view and then a sagittal lateral view, and you measure the amount of involvement of the sector. So if it is beyond, say 200, you take a call for surgery, okay. So if it's like less than 190 combined, so this is combination of both. It's not just this or that. A combination of both, you add up both of it, and then if it's less than 190 or 150, you can still plan on conservative. So how do you want to treat? So it's just simple, no rocket science behind. You just have to remove all the dead bone, and you want to improve the vascular supply, and you want to promote good bone growth there. So normal bone, you want to promote it to fill the cavity. So whatever dead bone is there, you want to remove it. So it's not so easy, you can't just go in, take a curette and just scoop out everything. No, it's not that easy, because the approach is too deep, right? It's not here, it's too deep. It's almost in the subchondral area of your ball and socket. So you need to approach it from a distance. So some of the methods are, you do a core decompression, like a friend told, increased intraosseous pressure because of the dead debris and the sclerotic rim. The pressure inside keeps building and building. Because of that build-up of pressure, patient will experience excruciating pain over a period of time. So in order to relieve that pain, you do a tunneling towards the site of lesion, and then you decompress it. So the pressure comes out, so symptomatically patient feels better. Second, you create a channel for neovascularization. You are making this pathway patent to the sclerotic lesion. You target it under an image intensifier. You put in a guide wire and you ream it till that area where you break open that sclerotic wall, and then you enter into the lesion, and then later you promote neovascularization. So how does the bone form here? So that phenomenon is called as creeping substitution. Okay. So just like creepers, the vessels just go along the channel, and then it substitutes the necrotic bone with good bone. So osteogenic progenitor cells migrate there, then you have this differentiation of blasts and sites, and blasts take over and start depositing normal bone. So that's one way. So do you think this is a very good treatment or an under treatment? So basically you have made a hole, you have drilled a tunnel, and then you've just come off. This whole area is hollow for another 8 to 10 months. What will happen? What will happen? Infection. That is, if you operate him on the parking lot, he will get infected. Anything else? Fracture. Yeah, exactly. So basically, whatever dead bone was there, you have removed and you have left it like a hollow space. Obviously, it's going to get fractured, right? So you want to protect it. So what special advice you have to give to the patients? Non-weight bearing. Stay in the bed, mobilize, do whatever you can to prevent DVT and bed sores, but no putting a foot on the floor. If he does that, he'll hear one noise. Next day he'll come with a neck fracture or a compressed head fracture. So that is very important. Okay, so counseling the patient is very important. Will you stay in the bed for 3 months? So you need to counsel them, prepare them mentally before they take up this surgery. Or else you don't, counsel them on discharge day. You tell them 3 months have to sit, then you will get a tight slap. So you need to talk to them. Okay, key is communication. Right? Okay. So which stage you want to opt this? Stage 1, stage 2, 3, 4. 4. Okay, so pre-collapse stage. Let's call it as pre-collapse stage. Okay. So all these things are suggestive for pre-collapse stage treatment, not after post-collapse, where the head is already flattened. Either you drill or you don't drill. What is the whole point? Already damage is done. Correct? So this is all pre-collapse. So that is why treating these people before they miss the bus is very important. Okay, so what is this? What do you understand by this? Some fancy thing he has done, na? So what's it? It's called as a rotational osteotomy. So basically, so the AVN is here, correct? The avascular necrosis is here. We make a osteotomy in the cervicotrochanteric junction and we rotate the head. Okay, we rotate the head in such a way that the disease part comes in the non-weight bearing area and the normal healthy part comes to the weight bearing area. It's just like replacing your spare tire, just for the time being. Okay, so the puncture tire goes to your dicky and then your spare tire comes back. That's all. So is this a good surgery? Why? Why it's not a good surgery? Yeah, you want to tell something? No, it's okay. Go ahead. Give it a shot. Okay, so after some time, the normal part also might get affected. Okay, so that is a very good point. Okay, but why do you think it will get involved? Okay, so basic pathology. So underlying pathology has to be addressed. If he is on steroids, you try to taper him or you completely take him off. So underlying, okay. Anything which might complicate just by this surgery? Yeah, exactly. How do you think you get compromised? So there is a retinacular vessel, right, which runs along all the surfaces of the neck. If you twist it, what will happen? Everything will tear. That is why this surgery was, done by only this guy, Sugioko. He was the one who invented it and he died with the invention. Nobody does it. Okay, but it's given in your book, derotation also. It's technically very challenging, and second, the outcome is very poor because if you see through microscope, these retinacular vessels actually rupture while you're rotating. So some people do a clockwise rotation, some people do an anti-clockwise rotation, but invariably when you're doing a 360-degree rotation, everything is going to like snap out. So invariably it's going to cause again AVN in the next quadrant. Okay, so you guys got it right. So simple as that, not to be done. Okay, so this is one more treatment. This is called as a trapdoor or a light bulb treatment. So here what happens is, we go up to the trans-cervical area, we make a small box like corticotomy, and then we use a curette or like this, a drill. We scrape out all the dead material of bone and then we use grafts. So we can take an iliac crest graft and it's pushed in. Do you think this is better? Yeah, comparatively it's better. Why? Because point one,
It's not hollow.
yeah, it's not hollow. You're restoring normal back, normal bone stat on the table itself. So you're not going to let this thing be hollow. Second, what is the next thing? Any other good thing about this? You're just approaching only one side of the neck. The other 240 degrees of the neck are still not touched. So vascularity is not compromised. It's just one side. So this is a very good treatment, right? So this is again one more thing which quite commonly people do. Okay? And then third, we can use a vascularized fibular graft. So how is this different from the previous surgery? So what material? Sorry? Okay. Okay. What about this bone material? What was used in the previous one? Cancellous bone. Tricortical bone from the iliac crest is cancellous. Which is more stronger? Obviously cortical bone. So will that help in the survivability of the head? So this is much stronger. So this will act like a pillar to a building which is about to collapse. So this acts as a strut graft and provides structural support to the femoral head. So this is one good thing about the fibular graft. What is the problem is neovascularization. It's very difficult to do. It looks very simple in this, but getting the artery and suturing it and for it to take off without a thrombosis is very crucial. Little difficult, quite challenging. But this is also being done. Okay, so again, these are all for stage 1 and stage 2, pre-collapse stage, not for stage 4. So stage 4 people come. What do you do? Stage 4, what do you do?
It's already collapsed, so shall we?
Yeah, so already head is collapsed. There is no point of keeping the head. You have to replace it. So what method will you use to replace it? What is this surgery? Total hip arthroplasty. Arthroplasty is surgically you replace the joint. So this is where the head is completely removed and then an artificial cup is placed in the femoral area and then the femur is fixed with a stem. So you are recreating a ball and socket artificially. Okay. So there are other surgeries which are called as surface arthroplasties where all these huge implants are not involved. It is just the head which is removed and then a small ball is being placed. So that's called as a Birmingham hip or a surface replacement arthroplasty. Okay, yeah. So any doubts? So very simple. So causes, you know. What is happening inside, you know. So how do you treat the patient? What investigations? X-ray, MRA, bone scan. Okay, and the total count so that you rule out other reasons. Then what stage the patient is? Stage 1, 2, 3, 4 by Pickett and Arlett. Then when do you decide upon surgery? Corbel index. Okay, and then conservative, NSAIDs, bisphosphonates, traction, rest, crutches. Surgical, stage 1, 2, pre-collapse stage, decompression, rotational osteotomies, fibula strut grafting, and trapdoor. Okay, and stage 4, collapse stage, we have very less options but to replace it. Okay. Okay, so summary of the topic is hip osteonecrosis is due to the reduced blood supply. Second, diagnosis of radiograph is to be done in moderate to late diseases. So stage 1 seldom can't be picked up in an MRA. Can't be picked up in an X-ray, but only in an MRA. Only the signal intensity will give away the disease, or else in X-ray you cannot find anything. Third, a good general observation with the management of underlying systemic condition. So that is very important. So it has to be a globalized approach. You can't just deal with the surgery and then let him take truckloads of steroids. That's not happening. And AVN is not confined only to the hip joint. It can happen in the navicle, talus, anywhere, jaw, mandible, anywhere it can happen. So you need to control that also. So don't keep your vision tubular. Last is operative management is to salvage. If not, late stage you go in for total.